Thank you so much, Mr. Mugisha. Good morning, everyone. Thank you so much for turning up in big numbers for this wonderful conference. It's very exciting to see a full house. Mr. Mugisha said, introduced me as one of the brains behind group support psychotherapy. Well, another brain behind group support psychotherapy who I want to acknowledge and I want to introduce is Mr. Wamala Kizito, the clinical psychologist. He's the lead in Moving Together for the last 10 years. Thank you so much, Mr. Wamala, for the good working relationship. I appreciate you. So, ladies and gentlemen, a little bit about my past, why am I doing this work? For that, I'm going to refer you to the TED Talk I gave in 2017. You can Google my name in YouTube, put TEDx, and then the talk will come out. It has the whole story, because I can't say the whole story. But I'm going to be brief and say that while I was on my PhD studies, I felt I was sliding into depression. And I went for help, you know, at the center where the students were told to go. And from there, I was told, after giving my story and everything, that there was no therapist who was a good fit for me. So I was sent back. And that experience motivated me to do this work and the work I do. And I don't want anyone to ever feel depressed and be told there is no therapist for you, okay? And this is why we started this work in government health facilities. As you've heard this morning, a lot of this mental health work is among refugees. How about our people? How about our health facilities where we go? People go there with depression, anxiety. Who is screening them? You know, no one, okay? Again, that is the other motivation. So we all know by now the biggest the most prevalent mental health problem is depression. You don't find it in Butabika, you know, you don't. You go and read the reports. The depression which goes to Butabika is psychotic depression, you know, severe. But the mild and moderate is in general hospitals, is in clinics, all right? So I saw this among persons living with HIV/AIDS, and it's actually because of them that I joined the profession and, you know, to bring mental health care into HIV care. So the problem is depression. It's affecting more than 350 million people. And as Dr. Naku said yesterday, the majority are living in low-income countries. And in 2012, 10 years ago, I did a study, a systematic review where I combined all studies across Africa. It was the first systemic review among persons with HIV/AIDS in Africa. And it showed 1 in 3 were having depression. 5 years later, the National Mental Health Institute in the US funded someone else to do the same study that I had done, and they got the same result. 1 in 3 persons with HIV/AIDS have depression. So this is the problem that we set out to find a solution. And why? Because it has negative health consequences. Persons with depression don't engage in care. They do not adhere to treatment. Therefore, they do not effectively suppress the virus. And, you know, this increases the likelihood of transmitting the virus. And so the HIV epidemic cannot end without the mental health interventions for depression. And the World Health Organization has recognized this. And last year, our intervention was nominated as an African innovative mental health intervention in persons who end up with depression. If our basic needs are not met, then we can't even think about our psychological needs, all right? So we wanted an intervention that would take care of basic needs as well as the psychological needs, which come much later when someone has the basic needs, has security, and is safe. Then they are going to start thinking about their mental health and how to protect it and how to promote it. So, in the interest of time, I am going to skip some slides, but here I wanted to say that when we are stressed, there is a physiological reaction taking place in our body. There's a physiological reaction, and this people don't know this bit of information. And if we do nothing to reverse that physiological reaction, our various organs in the body get damaged. Stress will suppress your immune system. Now, persons with HIV/AIDS already have an immune, their immunity is already suppressed. When they are stressed, the immunity even goes down further. So treatment of depression or alleviation of stress is part and parcel of HIV care. It targets the HIV virus, and I'm going to show you how later on. Okay. I like this slide very much because it shows the spectrum of mental health. And we're all on this spectrum, all right? On one end, your mental health might be good, excellent, you know? But what is going to make you shift along that spectrum is stress. And we all encounter stress in all shapes and sizes. Okay, so no one is immune, all right? So we have to know how to manage our stress so that we always, whatever we do, we keep on the good end of mental health. At the severe end, next please. Excuse me, can you show the next slide? That one. At the extreme end, in the red zone, that's where you have the severe disorders. You know, that's where you have patients going to Butabika. But before that, you know, people are deteriorating slowly by slowly. So we need to arrest that shift early on. And that's why I worked in Butabika for 10 years and then later left. Because for me, to sit and wait for someone to come with a severe disorder, it made me uncomfortable. I wanted to go for those people with mild problems and intervene there and then and prevent them from developing severe mental disorders. Okay, so next please. Next. Okay. Just before that, about the symptoms of depression, I want to mention that these symptoms can be physical, emotional, or cognitive, all right? It's not about someone looking sad, you know, or losing interest. In our context, people somatize a lot. People come to you with physical complaints, and we must know this as even counselors. Because someone is going to come to you with persistent headache, you know, you take their history, they've been to like 7 doctors, and they have the medical forms with you. They show you, they say, doctor, they're not seeing the problem, you know. We have to know that in our setting, people present with somatic symptoms, you know, and they need the psychotherapy or our counseling when they start to have these symptoms, and the investigations are saying there is no problem. All right, so this is the solution that we came up with. Next, please. Group support psychotherapy. Now, this is a CBT-based intervention. We got some components of CBT, presented them to the community, and asked if these are things they could, you know, or they would want to learn about, or would be easy for them to understand. Psych education is part of CBT, problem solving, you know, meaning making, you know, these things are part of CBT. So we just pick a few of those things, simple things. We took them to the community and asked them if they were okay with them. And they said yes. But this community also told us that, doctor, you can see we are in poverty. This poverty is also making us depressed. If you can do something about this poverty, doctor, the community will come to your intervention. So I hadn't thought about this. So I went back and read, and then I said, but these people are right. There's a whole literature saying that poverty is a potent risk factor of depression. So I went to Mr. Wamala, and I asked him, Mr. Wamala, what do we do? And then he told me, we have been doing some training in livelihood skills. So I tell him, you know what? I think you need to include that training in the manual. So what we do is that we developed a culturally sensitive intervention which aimed to treat depression by enhancing emotional and social support, teaching positive coping skills and income generating skills. Okay, and this is the structure of the intervention. It is 8 sessions. Participants meet once a week for 8 weeks. And in the first session, it's introduction. They get to know each other. They also get to know what the group therapy is about. How is it going to help us anyway? We must explain that, and they must understand why they are going to come. And then, of course, we get them to commit. And after each session, we give them homework. Now, this homework is not to go and write. No, it is an activity. And usually these are communal activities, they are social activities. We ask them to do and come back and report, all right? And the cultural sensitivity, we, again, using data from the community, we decided to make the intervention gender specific. Men meet alone and women meet alone. Why? Because our culture and gender roles are different. Men have different problems and women have different problems. And you can imagine which man wants to share their problems. We train equal numbers, okay? Equal numbers. And then the male health workers would then go into the community and, talk to the males and invite them, screen them and invite them in this group. The other cultural things, this group begins with rituals, cultural dance, song, prayer, whatever they want, These are some of the things we did to make it culturally appropriate. Okay, so or maybe just to go through the intervention. After introduction, the second session is psych education. We educate about depression and how it relates to HIV. Session 3 and 4, we then give each participant a chance to express their most painful problem. And we found that people had never been given this chance before. And these were the most favorite sessions of the community. After that, the health workers told us that the participants would be visibly changed. And now they were even more time conscious. They would keep time. They were even more eager to learn more. So thereafter, we would then teach them a variety of positive coping skills. And then thereafter, the income generating skills in the last 2 sessions. So we documented everything that we did and we published it in peer-reviewed journals. How do we get this intervention to the community? We designed a training program, following the TOT model. And our target was our health workers in our government health facilities. Because as I told you, when you go to northern Uganda, the counseling is 8 health workers from the HIV clinic, 1 male, 1 female. We convene them in town. Okay, actually, before we go to the health center, we would approach the district local government, and would have a stakeholders meeting, explain the project and then ask for permission. And then would approach the in-charge. The in-charges would nominate the health workers. So again here, I want you to note, it's not training just anybody. They had interest and they could commit, So they sent us those health workers and we met in town, trained the health workers, a 5-day workshop, and then they go back and step 2, they train the lay health workers or the VHTs. Now, before they train the VHTs, they have to convene the groups. They have to do the practical. Otherwise, you can't know these things from just theory. So we made sure that whoever trained had to do the practical, had to convene the group, once a week for 8 weeks. When you did that, you qualified. So you could go on to train the lay health workers. So then they went in the villages and they were able to convene the groups. Okay, so this is the model we have sold to the Ministry of Health, whereby the specialists, the psychologists, psychiatrists train the health workers in the clinics, and then those health workers go to train the VHTs. All right, next, let's go to the training objectives. So what do we train? a health worker. We train them to give a health talk on depression, to do the screening, and then we also give them the basic communication and counseling skills. They should be able to give the health talk by the end of the workshop. They should be able to demonstrate that they have learned various coping skills, the problem-solving skills, during the role plays that we play. And then they also demonstrate the ability to use the GSP manual, because we follow this during the training. And then also we train them about self-care strategies, because listening to people's problems is not an easy thing. You have to know how to take care of yourself. So we make sure this is part of that training. So I also wanted to go through the core competencies. You know, we teach these people to initiate contact. How would you start talking to someone you suspect may have depression? We teach them to screen. We teach them to deliver the intervention following the manual. And we teach them how to care for themselves. Okay, so after that, yes, we're out of time. Okay, I'm going to, so anyway, that's the program in a nutshell. So let me just quickly tell you that we have done randomized trials where we got 30 health centers across Gulu, Kitgum, and Pade. 15 health centers, and the other 15 health centers gave group support psychotherapy. And these are some of our results. We saw a dramatic decrease in depression 6 months after the intervention. And even 2 years later, we followed up these cohorts for 2 years. They have remained depression-free. So you can go through them up to the end. You can go through up to the last diagram because we're out of time. But I wanted to say that not only depression decreased, but these people, there was a decrease in suicide risk. People were asking about suicide. We have some detailed information on how we deal with suicide. There was a decrease in suicide risk. There was a decrease in alcohol use. And we have done more evaluations which indicate that actually the improvement was not only in depression, but also adherence to art improved, and also the participants, there was improved viral suppression. Now, our most recent work, which is this diagram, it shows that the improvement in viral suppression came as a result of treating the participants with depression. And them adhering was not enough, you know, to achieve optimum viral suppression. But when we added treating depression, the viral suppression improved. So this work is going to be published, and I'll be sharing the work for you. But it is our evidence that mental health interventions are part and parcel of HIV care. I want to thank you for your attention.